Hi, my name is Joe Scott. I'm the president and CEO of Jersey City Medical Center. We are welcoming you to the new Medical Center show. With me today is Dr. Mary Abed, the Chief of Cardiology. Dr. Abed, welcome. We're so glad you're here.
Thank you.
Tell us a little bit about yourself, your training and your experience. Tell us what you do.
I am Mary Abed. I am a board-certified interventional cardiologist. I trained at the University of California, San Francisco was my medical school training. I did my residency in medicine and cardiology and interventional cardiology, which was a lot of years at New York University in Manhattan.
So, a lot of people talk about living in Jersey City and going into Manhattan for their health care. You're a New York-trained doctor. Why do they need to go into the city?
Unnecessary.
Right?
Absolutely.
We have so many well-trained doctors at the medical center, and we've recruited so many new docs. And here we have our chief of cardiology who is trained at NYU. There's no reason for anybody to go into the city when they need good health care.
No, we offer tremendously good health care at the medical center across a broad spectrum of services. Absolutely.
It's true. A lot of questions I often get from lay people is, there's all these different types of cardiologists. Tell us a little bit about all the different types of cardiologists and kind of some of the services that we provide at the medical center.
Okay. So all cardiologists have done internal medicine first. So
Right.
We've spent 3 years learning internal medicine. And then we go into general cardiology, which is a 3-year training program. General cardiologists will treat all types of cardiovascular illnesses, high blood pressure, coronary artery disease, heart failure. Then there are cardiologists, after doing general cardiology, will go on to do electrophysiology. And electrophysiology is the cardiologist who specializes in heart rhythms. So if you have palpitations,
So when you say heart rhythms, what causes those rhythms? Is that something to do with electricity in the heart, or?
Yes, I mean, a heartbeat is generated by an electrical conduction system in the heart. And sometimes these malfunction.
So there's a cardiologist that just does work on electrophysiology of the heart?
Yes, absolutely. And they are called electrophysiologists. There are invasive cardiologists, and these cardiologists do
You mean they invade you or something?
They invade you.
What do you mean?
We like groins, we like wrists. And
you used to do invasive cardiology,
right?
right?
I did invasive and interventional. Invasive cardiologists will do a diagnostic catheterization or angiogram. Those terms are the same.
So when you say a diagnostic catheterization, you mean they're looking at your heart through a catheter?
Exactly. A catheter might be placed in the artery of your groin.
Right.
And it is thread up to the heart. And we take pictures of each of the arteries of the heart.
Okay.
When there is a blockage and it is deemed necessary for an intervention, a stent or a balloon, then an interventional cardiologist will do that procedure. Most interventional cardiologists are invasive. They always have to be invasive, but not all invasive cardiologists do interventions.
Okay. And what's their objective when they're doing that? Why are they in your heart with a stent or a balloon? What's going on there?
To assess why a patient may have complained of shortness of breath or chest pain, or a stress test has suggested to us that there is a blockage in one of those main vessels of the artery that feed that heart muscle blood.
And so they'll go in there, they'll put a stent in, and then that will open that vessel. And should they feel perfectly fine after that? I mean, what's the course? I think people get apprehensive about having those kinds of procedures. What's the course after they're finished? Well,
it's really, the technology has dramatically changed, Joe, the whole process of coronary interventions. The catheters and the stents are able to be deployed or placed in the artery, and angioplasty or stenting has now become a same-day procedure.
Right.
Patients come in, they have the procedure, there are plugs that are placed in the artery where before we used to sit there and hold the groin for 20 minutes or 30 minutes and all the fellows would get arthritis of their hands. But today there's a plug, they're watched for several hours, and they can go home the same day.
And then back to normal?
Pretty much.
They don't have to do anything? I mean, do they have to do any special exercises or?
Well, they must, when stents are placed, they must be committed to taking their medications. That's the most important thing in the early part of
After
having
they
that
have
stent.
happened. Okay.
Exactly, because we do not want the blood to clot around that stent.
Right.
Exercise and everything else that we're probably going to talk a little bit about are things that should be done prior to ever needing a stent,
Right.
and certainly after, to hopefully prevent the progression of blockages of the other arteries of your heart.
Now, you know, it's interesting. I just heard of a patient who actually was at work, and his workplace had a practitioner there who he thought he was having some indigestion, just wasn't feeling well, actually complained of an earache and jaw pain. And when the practitioner saw him, they immediately called 911 and brought him to our hospital, and within 23 minutes they were in the cath lab.
Mm-hmm.
How does that happen? I mean, we have cardiologists that are readily available to take people to the cath lab 24 hours a day?
Absolutely. The medical center has really been a leader in maintaining top-of-the-line care for cardiovascular diseases. And we provide services for acute coronary syndromes or heart attacks 24/7.
Mm-hmm.
Our staff is available, our doctors are available, there are call schedules, the ER has protocols. So those patients, we actually are able to communicate from the field to the ER, to the cath lab, that a patient is coming in with a heart attack before that patient even arrives at the door. So preparation has already begun before the patient gets into the hospital. And we offer that 24/7. We do it very well.
Now, are there nurses available also? I mean,
there's a whole team.
Okay.
There are nurses, there are radiology techs who have to help the doctor at the time of the procedure, and everybody has rotations and cover
so somebody
that lab.
comes in with chest pain, they call a code heart, and the whole team comes and gets that patient up to the cath lab as quickly as possible?
If the chest pain shows us that is a heart attack.
Right.
Not all chest pain is a heart attack.
Okay.
So
and
clearly,
so you have to differentiate that.
Yes, we have criteria that defines what that patient's treatments are going to be from the ED to wherever he is going to be transferred to.
Typically, how long does it take you to make that kind of diagnosis?
Within minutes.
Oh, it does.
An EKG will tell us immediately.
We'll tell you right away.
Absolutely.
That it's either something to do with your heart or something else.
Pretty much. I mean, there are different types of heart attacks that we can define on the EKG.
Okay.
All of you have been in the office and have had an EKG.
Sure.
If there are certain changes that we call an ST segment elevation heart attack, that patient goes right to the cath lab.
So that's when the thing's going like this and you see something on there that tells you it's an ST elevation, right?
I love it, Joe. Cardiology is a little bit more than things going like that.
No, but that's what you use to help you make that diagnosis,
yes,
right?
that EKG, and in fact, I have a poster that can show us what that is.
Yeah, let's look at the poster.
That would tell me when a patient has to go to the cath lab for an emergency angioplasty.
Okay, so we have a poster. Maybe we can kind of take a look. Is this the one you were looking for?
This is a chart that I actually keep in my office that I hope patients who are waiting for me actually get to read and look at. This is an EKG. It is actually just one pulse of an EKG, and there are very specific changes that we look for that will deem the patient a heart attack that needs to go to the cath lab because the vessel is completely closed.
So you're saying like one of these vessels is completely closed and they can't...
Here are the main vessels that feed the heart.
Okay.
One of those vessels, if one of those vessels close, we will see very specific changes on the EKG.
That's pretty cool, huh?
That tell us that patient has to go to the cath lab.
So because this is closed, this changes.
Absolutely.
Wow, that's really neat. That's really
and you can see here what the lumen of a normal artery is, the tube.
Right.
And as it progresses, it develops this plaque.
Oh, so
here we have
about
a
to close.
a 70% blockage of a vessel.
So at what point from being completely clear to this 70% blockage, do you think people will start to feel symptoms? Do you know? Does it vary based on how much blockage there is?
Yes, absolutely. Okay. Patients generally will become symptomatic when the obstruction exceeds 50%.
Oh, wow. Okay.
With exertion, with activity. That's why some people feel fine and have blockages, but that's because the blockage may not be severe enough to compromise that heart muscle.
Oh, I see. So like if they walk up the steps and then all of a sudden they're short of breath or they feel some chest pain, that's probably because
that heart muscle is exercising. When they're climbing steps, you need more blood flow, like to your legs when you climb steps. You ever get a cramp in your leg when you're really at the end of your exercise?
As a matter of fact, I do.
That leg muscle needs extra blood.
Yeah.
And when you're working the heart rate goes up. that heart muscle needs more blood. And obstructions like this don't allow an adequate amount of blood to reach that heart muscle.
Wow, that's really amazing. What's amazing to me is that you can take something like this, that you put all those electrodes all over your body, and it shows you kind of what normal is. But then as things start to change in the heart, this thing changes, and you guys can tell.
Right. And
that's like you're like a genius, you know?
Sciences. Sciences.
That's really incredible. That's something. So we're talking about cardiology. This is Heart Month. The medical center does a lot of different things. Are all the doctors at the medical center as well trained as you are and can provide the same kind of expertise that you do?
Yeah, all the doctors at the medical center, certainly since you've been on board with us, Joe, have had to show us that they are board certified or board eligible.
Right.
And everybody pretty much goes through a very good training process, and to be able to pass your board exams tells us that you have a good basic fund of knowledge.
Right. And so obviously we want to make sure that we maintain the highest quality care in our hospital, and we've set out an objective to be in the top 10% nationally for quality. And this last year, we were actually able to achieve that and are in the top 10% of all hospitals for the quality that we provide. How do you monitor that? How do you know whether a doctor is doing the right thing, the wrong thing? What kind of process is in place? Because families worry about that. They want when my mom comes to the medical center, I want to make sure she's getting the best care. And we want to do the same thing, right?
There are clearly guidelines defined by different societies.
Right.
And it behooves the institution to show that the hospital and its staff is abiding by the guidelines.
I see.
So we have in place numerous employees, nurses, techs, whose job is to evaluate patients who've been in our institution and have the guideline protocols been fulfilled.
Okay.
And it is my job to make sure that all of my division in cardiology is fulfilling those guidelines. And we work very hard to make sure that we are treating patients in the most adequate and superior aspect of medicine today.
You know, I've been so gratified because once we started talking as a team between the administration and the nursing staff and the medical staff about why it was important for us to be in the top 10%, everybody's pulled together and have really made this happen. It's really changed the way things happen at the medical center, and it's a tribute to you and your staff and everything we're doing. We're going to be right back. We're going to take a break, and we'll be back in a couple minutes.
Thanks.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by U.S. News and World Report. Hudson County's only hospital to receive an A safety score rating. Jersey City Medical Center is Hudson County's only hospital to receive the prestigious Magnet Award for Nursing Excellence. Make the #1 hospital in Hudson County your first choice for quality health care. Jersey City Medical Center. Visit us on the web at libertyhealth.org.
Panapinto Properties, Jersey City. Shaping the workplace with state-of-the-art office space and an address your company desires. Building residences that define your home environment. Adjacent to all modes of transportation. On-site parking available. The right address, the right lease. 201-521-9000 or visit on the web at panapintoproperties.com. Panapinto Properties, building Jersey City for everyone.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by the U.S. News and World Report. Why? Because of its patient care, not its bottom line. Jersey City Medical Center, for patients, not for profit. The Jersey City Medical Center accepts all patients and most insurance. At the Jersey City Medical Center, your health is our concern, not our bottom line. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center, for patients, not for profit. Visit us on the web at libertyhealth.org. Seeing the ER doctor at the Jersey City Medical Center has never been easier. If you're sick, you just click. Go to libertyhealth.org, and here's how it works. Click Skip the Wait. Select your time and check in now. Enter your symptoms, your personal information. Click Proceed to Confirmation, and the doctor's waiting for you. The Jersey City Medical Center. Make Hudson County's #1 hospital your first choice.
Hi, welcome back. My name is Joe Scott. I'm with the Jersey City Medical Center. I'm the president and CEO, and I'm here with Dr. Mary Abed, our chief of cardiology. And we're talking about cardiology. You know, it's Heart Month in February, and so we wanted to bring Dr. Abed out and talk a little bit about cardiology. Dr. Abed, we were talking about different things that the medical center does, how we're striving to be in the top 10% and actually have met that goal in 2012. One of the things that we focus on is heart failure. Tell us a little bit about what heart failure is. How does somebody know they have heart failure, and why they should be concerned about it?
Heart failure is a leading medical problem in this country, in the world, in fact.
Oh, really?
And heart failure is simply pump failure, that the heart muscle itself does not pump well. And I'm going to focus on that type of heart failure because that is more common than what we call diastolic heart failure, where the heart muscle is too stiff.
Okay.
Heart failure.
So most people just have the first kind of heart failure.
What we call systolic heart failure,
okay.
where the
right.
pump doesn't work.
It's not pumping as hard as it should.
Doesn't pump,
okay.
And the pressures in the heart go up. Remember,
right.
the heart is connected to the lungs.
Right.
So if the pressure in the heart goes up, backs up into the lungs, and one of the main symptoms of heart failure is shortness of breath.
So that's why people get short of breath, and it's because of their heart, because the fluid's backing up into their lungs, and that's almost like they're drowning, right?
Well, that's exactly what somebody who's been in heart failure will tell you.
Wow.
And we've spent a tremendous amount of time and energy. I've had a great staff with the nursing staff and the nursing teaching coordinators who've put together a very good booklet on how to treat and take care of yourself with heart failure once you go home, because it's critical that patients maintain their medications, that they weigh themselves daily, that they pay attention to the foods they eat, that they meet with their doctor. And we've got a great team that's put together a whole teaching tool for patients who come in heart failure.
Now, one of the problems, I know because my dad had heart failure and actually ended up dying of heart failure. And one of the things that I saw towards the end of his life was he kept getting admitted to the hospital. You know, he'd be out of the hospital and then go back in 2 weeks later, and then another week later, and eventually he couldn't leave the hospital. But why does that happen? Why do they keep going in and out of the hospital? Is it just their heart's not pumping, or?
I mean, at some point, you know, you can have what's called end-stage heart failure, and this heart muscle is not going to pump despite medications, and the goal for us today is to prevent that from even occurring, to identify the patients at risk. Who's at risk for developing heart failure? It's the patient with high blood pressure. It's the patient with coronary artery disease. It's the patient with diabetes. So these patients are at risk for systolic heart failure. And so it really is the goal of the entire medical community and the hospital to identify those patients and stop them from getting to that point of no return, if I may.
I see. Okay. And so tell us, let's talk a little bit about risk factors. So there's risk factors for cardiac disease, and then once you have that cardiac disease, that could lead to heart failure.
Absolutely.
So what are some of those things that are going to put people at risk? And before I stop, is it different for men than women? And, you know, how's that whole thing work?
Well, it's a very good question, Joe, and thank you for introducing the potential difference in gender treatments. Risk factors for coronary artery disease, and that is blockages of the arteries, are really the same for men and women.
Oh, they are?
High blood pressure, high cholesterol, obesity, diabetes, I said high cholesterol.
Yes. Hypertension.
Hypertension. So those are risk factors we know that if we treat and control, we can reduce the incidence of the disease. We can reduce the number of heart attacks.
So by controlling your diabetes, that can help you not have heart disease in the long run, or mitigate some of the risks associated with that?
It can mitigate different types of damage on the vessels. Diabetes really is a disease of vessels. And there are tiny vessels and the bigger vessels. And diabetes really can affect the small vessels in the heart muscle, in the eyes, in the kidneys. So it protects microvascular disease when you can control your blood sugars.
So that's why we have patients with diabetes get their eyes checked, because of the vessels in their eyes. Isn't that amazing? And so that can also affect your heart.
Absolutely.
Wow.
Absolutely. And in women, diabetes is probably a bigger effect and prognostic indicator for women than for men. So a diabetic woman, when she comes into the hospital, will be sicker than her male counterpart.
Wow.
Because they're generally 10 years older, they're generally more hypertensive.
Wow.
And they generally haven't sought medical care for a longer period of time.
They're taking care of everybody else, and so they leave themselves to the end.
Absolutely.
Right?
I really think that has really changed in the last 5 to 10 years because we've now do studies that enroll women.
Right.
You know, prior we simply extrapolated the data on studies from men and applied it to women. But women are truly not men.
Yeah. But,
it took us a long time to figure that out, Joe.
Well, I knew that, but I don't know why these doctors didn't know it. Anyway.
Well,
but what about young women versus older women? Isn't there a difference in the risk factors for young women versus older women?
Well, that's a good question, Joe. And age itself is a risk factor.
Okay.
So obviously, for men and for women, as women age...
Not that you're getting older, but as I get older, then I'm at more risk for having problems with my heart.
Yes, I mean, age is a risk factor.
Right.
I always
Mary's only 20, everybody, so we don't have to worry about that.
22.
Oh, 22? Okay, all right,
birthday.
that's right. She graduated medical school. She's now 22.
You know, when we talk about risk factors, Joe, I like to break that up into those that are modifiable, those that I can treat and adjust, but there are not modifiable risk factors, and that includes age, that includes family history. So if your father had a cardiac event before the age of 55 or your mother before the age of 65, that portends, that puts you at risk for a genetic abnormality that I can't change that. So those you can affect, but it's the other bigger list that we can affect. So older women, because they're older, there's loss of estrogen, and estrogen has always been a very big question. Is estrogen protective?
So as women go through menopause, they lose their estrogen, and there's some theory that says that estrogen might protect the heart?
Well, certainly we know that estrogens have a very good effect on their lipid profile.
I
so
see.
There are some very beneficial effects of estrogen that protect the vessels and the lipid profile. But the studies have been very interesting and have shown in postmenopausal women, hormone replacement therapy is not protective. And today, in the year 2013, it is not a treatment that we should use to prevent coronary disease in women or prevent a second heart attack in somebody who already has heart disease. But I think there's so many questions about the use of estrogens, when to start treatment, how much to treat.
Some of the risk factors associated with them.
Yeah, right now we don't use postmenopausal estrogen therapy, but we treat them according to their risk profile.
Now, one of the most widely prescribed drugs now are lipid-lowering drugs and drugs for cholesterol. It seems like everybody I know is on some type of cholesterol.
They're going to put it in the water.
They're going to put it in the water soon?
I think.
Okay, so that'll keep our cholesterol low. But they're not without some side effects. So tell us a little bit about how you determine whether somebody should be on a cholesterol drug. What things do you look for? There's a lot of talk about the side effects associated with these. And tell us a little bit about what...
You know, Joe, of all the risk factors that have been studied that are attributable to the development of coronary disease, the statins have been the most extensively of all the statins.
Those are like Lipitor and Crestor and all
Crestor, Zocor, Provocol, Mevacor,
there's a million of them.
There's a lot of statins on the market. And clearly, every study has shown, whether it's what we call primary prevention to stop the first heart attack from occurring or secondary prevention, statins reduce those events.
Oh, they do? Wow.
And they are tremendously beneficial. And who gets put on a statin really depends on what is their risk profile when they present to the physician. And what is their cholesterol, their LDL, their HDL. And that's the real...
Wait a minute. You think they know what LDL and HDL is? So tell them what LDL is. Is that good, bad?
LDL stands for low density lipoprotein, and it is the bad cholesterol because it helps take. It is a carrier that will take cholesterol into the vessels.
So low is the bad number.
Low is the bad
one. Okay.
HDL is a high-density lipoprotein and actually keeps cholesterol out of depositing in the wall of the vessel.
Oh, wow.
Keeps it from floating, takes it back to the liver, lets it get metabolized some more. So it depends on all those numbers and what other risk factors that patient has that helps us decide, does this patient need a statin and how much of a statin? But there are some side effects. You know, you can get muscle aches, you can get joint aches.
So, but before we go there, because I want to ask you how you monitor that, but so what numbers, what do these numbers mean? You know, I get my cholesterol done and, you know, because you helped treat me. But
Joe's a very good patient.
I am trying to be a very good patient, but they were really high at one point. So is 100 a good number? What do those numbers mean?
Well, we look at total cholesterol, but we really look at the breakdown of the HDL and the LDL.
Right.
So any patient who is high risk, and by high risk, I mean any patient who has diabetes,
right.
any patient who has an abdominal aortic aneurysm,
right.
any patient who has carotid disease,
right.
any patient who has kidney disease, chronic kidney disease. Those patients are automatically at high risk.
Right.
And so for them, our goal in treating their cholesterol is to get that LDL below 100.
So that bad cholesterol, the LDL number has to be below 100. Okay.
Mm-hmm. The other groups depends on intermediate risk or low risk,
right.
and what other habits they have. Smokers will depend on what LDL goal is.
Right.
But in general, we like to see LDLs of less than 100.
Okay. So,
but most treatment in the intermediate or low risk won't get started unless the LDL is above 130.
Okay, so that's good information for people to know.
Absolutely.
Who should have their cholesterol checked?
Everybody.
Everybody should have it checked.
Children.
Okay, and yeah, that's right. You know, we recently did a health fair and we were actually testing children for cholesterol. Mm-hmm. Why would a kid have high cholesterol?
Genetics.
Genetics.
There's a lot
dietary
of enzymes
habits?
in the liver that help break down fats in our body.
Right.
And some of those enzymes are deficient, and that's why people have high cholesterol, high triglycerides.
Wow.
And depending on your family history, you can identify that patient population early.
And then we try to treat them with diet or exercise, or do you give kids those drugs?
All of the above, Joe.
Really?
I mean, predominantly, especially with kids today, and we're entering an era of an epidemic of diabetes and obesity amongst our children, it is imperative that we take these games out of their hands
and make them run around the block, right?
And give them a pair of running shoes or a basketball and go outside and play.
Yep.
We are entering a scary stage because if the epidemic of obesity and diabetes goes up, what we have done with the incidence of coronary disease going down, it's going to climb again because we are developing a population of people who are at high risk.
Right.
So it's all of the above.
Wow. Hey, listen, this has been great. I think we gave a lot of people a lot of information today. Dr. Abed is our premier cardiologist at Jersey City Medical Center. She has an office here in Jersey City, and she has 3 partners. Actually, I'm hoping that she's going to expand that practice even more. We do a lot of great things at the medical center. We're here to provide you with some great information. Thank you, Dr. Abed, for being with us today.
Thank you for inviting me.
And we hope you tune in to future medical center shows. Coming up, we have our Chief of Cardiovascular Surgery, who will be on a future show as we highlight Heart Month this month. So stay well, everybody, and see you at the next medical center show.